So it gives me a great pleasure to introduce to this afternoon's moderator, Dr. Robin Green. She's a senior scientist in cognitive neuroscience at the TRI, University Health Network, a Canada Research Chair 2 in traumatic brain injury, and a clinical neuropsychologist. Her research addresses brain and behavioral mechanisms of recovery from traumatic brain injury, in particular impediments to recovery and how to treat them to improve outcomes. Her lab's research focuses on reconceptualization of moderate severe brain injury as a progressive disorder, examining cognitive and neural deterioration in the chronic stages of injury, and developing treatments to offset neural decline, with a particular emphasis on the hippocampi. She's co-lead of the Schroeder Brain Institute, overseeing remotely delivered treatments to patients in their homes through participation in research. She's completed her PhD at Cambridge University, her postdoc at St. Guy's and St. Thomas's Hospital in London, England, and her clinical neuropsychology at the UHN in Toronto. Here's Dr. Green.
Thanks, Dr. Tartaglia. Welcome back, everybody. So it's my great pleasure to get to introduce Dr. Noah Silverberg. Noah is a colleague of many of us here in Toronto, and I'm familiar with the wonderful work he's doing. So Dr. Noah Silverberg is a board-certified neuropsychologist at GF Strong Rehab Center and a clinical associate professor of physical, medical, and rehabilitation, physical medicine and rehabilitation at the University of British Columbia. He holds a Health Professional Investigator Award from the Michael Smith Foundation for Health Research. The focus of his research program is on the prognosis and treatment of mild traumatic brain injury, concussion, as well as knowledge translation in primary care. Dr. Silverberg serves as chair for the American Congress of Rehabilitation Medicine Mild TBI Task Force, he's a journal and grant peer reviewer, expert panel member for clinical practice guidelines, and club neuropsychologist with the NHL and MLS. So, is your talk loaded? Yes? Okay, here we go. And so Dr. Silverberg is going to be talking about psychological mechanisms underlying persistent symptoms after concussion.
Thank you very much, first of all, to Charles and Robin for inviting me today, and thanks for your attention over these next 40 minutes or so. So for arguably most any disease is best understood from a biopsychosocial perspective, and we've heard a lot about the bio this morning, and I hope you're willing to turn your attention to the more sort of psychosocial aspects of concussion and mild traumatic brain injury. So I'll just give you a minute to peruse my potential sources of bias, I guess, sources of research funding and otherwise. And just sharing my own opinions today, some of our research and relevant research from others. So these are the things I'm hoping you'll get out of the talk today. First, just an appreciation for the importance that psychological factors play often in the recovery from concussion. We'd like you to be familiar with some of the specific psychological factors. So rather than just referring to them as psychological factors, we'll try to add some specificity to that today. And we'll talk a little bit about implications for treatment and clinical management of these patients. So much of the work that we heard today and much of the work that's being published in scientific journals is very focused on sport-related concussion and cumulative exposure to collision sports. That's really not what I'm going to be talking about here. The patients who we enroll in our research and see clinically tend to get injured in more common ways, the car accidents, falls, workplace injuries, and so on. And often have a single injury, sometimes a couple, but rarely more than that. So that's really the population I'm going to be focusing on today. So the first point I want to make is that psychological factors matter. And this is something that we've thought for a long time. So here are some selected writings on this topic going as far back as the 20s, referring to mental stress as an important aggravating factor. Another, I think this is from late 30s, some anxiety is normal but can easily become pathological. Emotional factors are inextricably bound up with the process of recovery. Physical symptoms are often slight, and this is referring to patients who are in chronic stage of recovery, but are grossly aggravated by psychological factors, particularly anxiety. So this should probably sound familiar, and this is sort of what was thought, even prior to World War II. But just to get up to date with what we've learned since, we now have quite a bit of research evidence to support this idea. I'm not going to go through it all, but I'll attempt to summarize it briefly. So we did a systematic review of all the available science a couple of years ago, looking at predictors of outcome. And in the various studies that we included in this review, they looked at a whole range of different potential risk factors, including demographic and then prior injury, characteristics of the injury itself, like whether there was a loss of consciousness or not, or an abnormality on a CT head scan and other symptoms as well. And of all of these potential predictors, the two that stood out most strongly were these: having a prior history of mental health difficulties before the concussion, and having a lot of anxiety in the days and weeks following concussion. So we thought that was kind of compelling. And then since we published this review, there's been a number of other studies. I've listed a bunch on this slide showing essentially the same thing, that pre-injury mental health difficulties, sometimes in the same studies, and early post-injury emotional stress are among the most robust or strongest predictors of outcome in prospective inception cohort studies. So studies that found patients in the emergency department and follow them forward over a period of time, typically at least a few months. Here's just one rather dramatic example. Trying to predict outcome from an MRI scan, in particular volumetrics and morphology measures. And you can see this study found no relationship with outcome. In contrast, if we look at early psychological stress, it relates quite strongly to outcome. So that has led a lot of scientists to make a statement somewhere in their paper about the potential role or importance of psychological factors, which I think is true. But as I said, we're hoping to add some specificity to that. So, how do we get from an injury to a poor clinical outcome? Some patients have persistent symptoms. What's in this black box of psychological factors? And this is what we're trying to find out. And I argue that this is important, not just to advance knowledge, but also to get patients better. So we have to be really clear about what our treatment targets are. And if we can do that, we can work sort of backwards through the mechanism of action to find active ingredients, what clinicians and therapists need to actually do in order to modify some of these risk factors and improve recovery. So to do this, I would also argue that we don't need to start from scratch. I think it's helpful to look at theoretical models that have already been developed for other health conditions that bear some similarities to what we see in persistent symptoms after a concussion. This can give us some ideas about what those psychological factors might be. This is an example of a model referred to as a fear avoidance model that's been around in the chronic pain literature. So this is typically pain after a musculoskeletal injury. And I'm just going to highlight one example of a psychological factor and show you how it's a part of all of these different models, and that is hypervigilance to symptoms. So just, paying a lot of attention to how you're feeling in your body, any problems you're having. That's all we mean by hypervigilance. This one's harder to read, but this is a cognitive behavioral model of chronic subjective dizziness. Here's one for chronic fatigue syndrome, and again, here you see focus on bodily symptoms as a part of that explanatory model. Insomnia. Headaches, I don't have a nice diagram to go with it, but you'll have to take my word for it that it's a part of this model as well. Also, if we look at models of somatization and medically unexplained symptoms, again, in each one of these, we see the same factor of, a lot of attention to symptoms and then to the body as being one part of the explanation of why some of these patients may experience a lot of ongoing symptoms. So looking across these different cognitive behavioral models, they have a few things in common that are worth highlighting. These models show that what patients believe and what they do, often in response to those beliefs, that's part of the model. How beliefs and actions reinforce each other. So if you have a certain understanding of where your symptoms are coming from, you act on that understanding, and that can reinforce your belief. And hopefully this will be clear as I go. They also say something about the mechanisms by which beliefs and actions contribute either in a helpful or harmful way to recovery. They acknowledge the potential role of social factors in recovery, and also that pre-illness traits and life experiences can either predispose somebody to a poor outcome or help protect them from one. So I'm going to go through some of the beliefs and actions that we now have some evidence for that should be in, what will eventually be, I think, a cognitive behavioral model of concussion recovery. And these are the ones that I'll go through. So here's sort of it phrased the way a patient might say it. Concerns about the permanency of symptoms, attributing symptoms to entirely the brain injury and nothing else. Ideas about injustice, that they've been wronged either because of how they got injured or the way they were treated afterwards, and their own self-efficacy, their ability to cope with this. So it's been shown in multiple studies from multiple continents that the more that people expect to have long-term problems after a concussion, the more likely they are to have long-term problems after a concussion. This is even after adjusting for the severity of their initial symptoms. And I'll just mention that also this isn't unique to concussion. We've seen this also in whiplash and chronic pain and other conditions like that. So expectations seem important. Here's some of our own data. This is a prospective cohort study we were running in Vancouver for a couple of years, recruiting from concussion clinics. And we asked patients at the time they first show up to clinic about their expectations of their recovery. And the ones who expect to recover soon have a much lower risk of having persistent symptoms than those who expect to recover slowly or not at all. They're uncertain. You can see virtually all of those patients went on to have long-term symptoms. So where do patients get their expectations from? There's obviously a lot in the media. All that attention has, I think for the most part, been very positive in terms of raising awareness for a concussion. It may have also led to the impression that concussions are very bad and scary for most people, which we don't think is entirely true. People also might have prior life experiences with other kinds of illnesses that may make them pessimistic about the recovery from concussion. They may have certain personality traits that, again, make them vulnerable to having these pessimistic expectations. Just to highlight one example, there was a poll done by the University of Pittsburgh Medical Center a couple of years ago, just asking people in the general public what they believe about concussion. Perhaps some of you have seen this. And these are some of the more sort of alarming concerns that people have. So if this is what you believe and you get a concussion, you're probably going to have a hard time being optimistic about your recovery. Misattribution may be another factor. So when we talk about the symptoms that follow concussion, like headache and fatigue and irritability, these symptoms, of course, are not entirely unique to concussion. They are also a part of everyday life and more common if a patient has comorbid conditions like depression and bodily pain and so on. We find that patients who have a lot of symptoms after concussion tend to attribute pretty much all of their symptoms to brain injury, which again may underlie pessimistic expectations for recovery. And then it's also sometimes difficult for patients to remember accurately how life was like before their injury. We find sort of a systematic bias in remembering the good old days, that things were better than they actually were. And we don't exactly know why this is. There's a couple of different possible mechanisms. One is that just by the mere passage of time, we tend to look back and think about our lives as being better off than we are now. That's just a trait of humans. It may also be that after a negative life event, not necessarily a brain injury, but anything that bad that happens, that may prompt people to think about their life in terms of now versus before, and think about before more favorably. Or there may be something specific about having a concussion that does this. So others have looked at this. This is an example of a study that we did showing that, on average, people who have had a mild traumatic brain injury or another kind of orthopedic injury below the clavicle report having had fewer of these post-concussion-like symptoms prior to their concussion than if you just ask healthy people, which of these symptoms are you having right now? So that suggests more of a sort of non-specific mechanism. However, we also think there's something unique about having a concussion. So what this slide is showing is people who have high symptoms after a concussion, a high symptom burden. They're a lot less likely than our orthopedic control patients to acknowledge having high symptoms prior to their injury. And they're also much, much more likely to report having none of these symptoms whatsoever prior to their injury. So just more evidence of this good old days bias phenomenon, and may be one of the reasons why people don't feel as if they've recovered. Another psychological factor that we've taken interest in recently is perceived injustice, this sort of blame about the circumstances in which the injury occurred, the losses somebody's suffered, and how they've been treated unfairly following their injury. And there's evidence from other conditions, as I'm showing here on the slide, that perceived injustice is associated with worse clinical outcomes. So we've just looked at this in concussion, and the same seems to be true, that perceived injustice correlates with just about everything bad after concussion. So patients who have high perceived injustice also tend to have a lot of symptoms, and also more depression and post-traumatic stress and more pessimistic expectations for recovery, and all of these things which we know to be risk factors for prolonged recovery. Catastrophizing is another concept that comes from the chronic pain literature. It's thought of as this negative mindset about symptoms that you're currently experiencing or might experience. And patients who are high on this dimension tend to think a lot about their condition and how dire it is, and feel quite helpless and hopeless about doing anything about those symptoms. So to date, there's only been one study showing that this seems to be at play in concussion as well, but I understand there's a lot more work coming in this area. So again, this is just a summary of the beliefs that we've looked at so far. Now we're going to turn our attention to some of the actions and ways that people go about coping with their symptoms that may not be entirely productive. And these are the two I'll focus on. And again, stating it in a patient's perspective, so avoiding things that might make their symptoms worse, or on the other hand, a tendency to overdo it and then crash. So this sort of yo-yo pattern of activity of going until they can't go no more, having an exacerbation of their symptoms, feeling really unwell, and then being quite inactive for some period of time before they start getting going again. So kinesiophobia, many of you are probably familiar with, also comes from the sort of musculoskeletal injury literature, where patients with pain are afraid to move or bend or position their body in ways that might exacerbate their pain, and as a result, their world can be rather limited. So we started wondering about whether something like this happens in concussion, but maybe more around fears of mental exertion and the possible consequences of mental exertion, such as brain damage or headaches. Not to say these are causes of mental exertion, but some of the things that patients seem to worry about. Again, we've recently looked at this in the same cohort study that I mentioned, and found that, not surprisingly, people who score high on cognophobia, so they report that they really go out of their way to avoid mental exertion out of concern of headaches and brain damage and other things, tend to have worse headaches. They also exhibited a more avoidance coping profile. So they're probably avoidant of other things, not just mental exertion. And there was some relationship, albeit not a very strong one, with their neuropsychological performance as well, suggesting that, and again, this would sort of make sense, that if you're concerned that if you concentrate too hard or too long, you're going to get a headache, you're probably going to avoid putting yourself in that situation and maybe hold back a little bit with mental effort. So then we took this a step further and measured avoidance coping in a bunch of different ways. There isn't really a validated measure of this after concussion, so we just took a bunch of measures and then created this composite score that accounted for all of these different dimensions of avoidance. We also mentioned endurance behavior, which is that sort of yo-yo, all or nothing style of coping that I mentioned a few minutes ago. So these are the kinds of statements that a patient would read and endorse whether they do this or not, overdoing and needing to rest up, pushing myself until I can't push myself anymore, that sort of thing. So this is thought to be sort of the polar opposite of avoidance behavior. And there had been one prior study showing that this was a pretty strong predictor of concussion recovery. So we put those into a model, and we looked at a range of different clinical outcomes, including post-concussion symptoms, disability, return to work, and psychiatric complications. And with the exception of return to work, there may be a lot else going on there. Both avoidance behavior and endurance behavior were significantly related to poor clinical outcome, however we measure it. And also that they were minimally related to each other. So there are patients, as we've learned, who have both of these coping styles, which we're still trying to get our head around, but for the most part, they weren't the same patients. And this fits with recent developments in the psychological mechanisms underlying chronic pain, the thought that there might be more than one pathway to disability. So yes, excessive avoidance can be problematic, but there are other ways of coping, including this endurance or all or nothing style, that are also problematic and may lead to disability. So the data just shown on the last few slides was just published last week. So if you want to read more about it in the Journal of Neurotrauma, there's the reference for it. Social influences. We don't know much about how family members respond to illness behavior, for example, in supporting or dismissive, invalidating ways, or health professionals, workplaces. Presumably the social context that patients are in can influence their recovery. There's been a little bit of research looking at diagnostic threat, this idea that if you draw somebody's attention to the fact that it's common for people with concussion to have these problems, we're going to give you some tests that look for these problems. That kind of introduction to the testing may induce performance anxiety, and that patients end up not performing well. And although there was a sort of a seminal study done some years back, it hasn't really been replicated, so I'm just not certain that this is an important factor. Some have also looked at pre-injury characteristics. Again, people have thought for some time that a person's sort of personality constitution is an important predictor of how well they recover. You've probably heard this phrase before, maybe not in context, but it's not only the kind of injury that matters, but the kind of head that gets injured. Does that sound familiar? This is where it comes from. So traumatic experiences through one's life or adversity, there's some evidence that that puts people at risk for persistent symptoms after a concussion. The sort of flip side of that is resiliency, which is thought to be a personality characteristic associated with this ability to bear adversity and bounce back, has been associated with favorable recovery in at least some studies. And there's really scarce evidence on some other factors that have been hypothesized. Personality traits like neuroticism, somatization, anxiety, sensitivity, which is very related to sort of body vigilance to symptoms and getting real concerned about bodily symptoms that one notices. This is another study we're working on now, investigating the role of somatization. So the thought is, if anxiety and how anxiety shows up in the body is one of the contributing factors after concussion, there shouldn't be anything special about concussion symptoms. This should occur with other kinds of symptoms as well. And so we asked patients who have had a concussion about a wide range of symptoms, those that we typically attribute to concussion, and other ones like GI discomfort and shortness of breath. And there is some evidence that patients with persistent symptoms after concussion also have a range of other symptoms we wouldn't typically associate with concussion. So that said, there's still a lot that we don't know. And here are just a few examples. So some of the maladaptive illness beliefs and coping behaviors that I've at least alluded to, like hypervigilance to the body, based on related health conditions we would expect would be important here as well, but we just don't have evidence for that yet. We also don't have a good understanding of how these different model components interact with each other to perhaps magnify disability in some cases. We also don't know much about the social factors, as I mentioned. And here's just another example of what I mean. So John Letty's not in the audience here, right? I will tell him that I literally put words in his mouth for this slide, but just to illustrate that I think as health professionals, the words we say matter, and they might give people impressions that influence what they think about their condition and how they cope with it. So, for example, it's becoming more common to do exertion testing after concussion as a way of helping to assess recovery. So, for example, a patient is put on a treadmill or a stationary bike. And the protocol is to, pedal or run faster, harder to provoke concussion symptoms. So my sense is if the test is introduced in this kind of non-specific way, we might see a different response than if the test is introduced with instructions that create a clear expectation of what symptoms, this test can provoke symptoms, what symptoms to expect. And if we ask the patient, as is done in a lot of these standardized protocols, how are you feeling? How are you feeling now? How are you feeling now? Really encouraging that close attention to bodily sensations, which may make patients more likely to notice them and to amplify them if it causes concern. Anxiety can often, worsen a headache that started or lead to changes in breathing that cause lightheadedness and create more dizziness and so on. So this is something we're studying experimentally now, sort of randomly assigning people to one set of instructions or another before they do a physically or cognitively demanding task to help better understand this better. We also don't know much about how these psychosocial factors relate to our biology. There are, again, here other helpful models. This is an example of a biopsychosocial model of the nocebo effect. Nocebo being the opposite of placebo, when patients expect to have adverse side effects after a sugar pill, benign medication or something that might create anxiety and sets off this sort of neuroendocrine cascade in the body that may help explain how the symptoms actually show up when the medication itself doesn't have any biological activity. Okay, so I'm just going to turn in this last bit to treatment. Based on what we've covered so far, we should have some ideas about what might work and what probably won't work. And our thought is education and reassurance is important and is a good idea to dispense routinely. But for some patients, it's probably not enough. So there does seem to be a select group of patients for whom education and reassurance does nothing. They stay on that trajectory towards a poor recovery. And if you think about the health anxiety literature, so patients who are really anxious about their health condition, have very fixed beliefs about what's wrong with them, if you reassure them, they feel better for a little bit. And then that effect wears off, and then they have sort of renewed anxiety and disease conviction, and then you could reassure them and they feel better, but only for a short little while. This is what this graph is supposed to illustrate, these classic experiments that were done looking at the effects, short-term and long-term, of reassurance on health anxiety and beliefs about one's health. So what should work? Well, theoretically, if these cognitive and behavioral factors are contributing to poor recovery, then cognitive behavioral therapy designed to modify those factors should be of help. So this is something we've started to test out. This is an example of a pilot randomized control trial that we published a few years ago, recruiting people. They're about a couple of weeks, after their injury. We tried to pick people who are at high risk of having a poor outcome because they had some of these psychosocial risk factors that I've mentioned. And we ran them through a 6-session protocol targeting some of these risk factors, as I mentioned. So trying to get them to be a bit more optimistic about the recovery, to focus on getting back to life, and a bit less focused on forgetting their keys or the other symptoms that they're experiencing. Using pretty traditional cognitive behavioral techniques like cognitive reframing and behavioral experiments and so on. And we showed that patients who got the CBT at the end of the treatment and at follow-up were doing a bit better with regard to their symptoms and disability, and also some of their maladaptive health beliefs. Some of the other things we were directly trying to change, and were less likely to have persistent symptoms after concussion. Granted, it's a very small sample. There's been a few other trials of cognitive behavioral therapy lately. This one with quite chronic patients. and another one with early patients, but all comers, so not those at particularly high risk of anything. And this study did not find that CBT was helpful, possibly because they gave it to everyone, no matter if they were at, sort of high risk and had some of these psychosocial risk factors or not. The next thing we're trying to do is be a bit more specific with our treatment. So rather than just CBT for everyone, we want to sort of apply these principles of precision medicine to try to tailor treatment a bit better. So I mentioned a few minutes ago that avoidance and endurance seem to be distinct ways of coping and then possibly pathways to disability. Avoidance being characterized by catastrophizing, hypervigilance to symptoms, and having high sort of dangerousness beliefs about activity. And endurance, these are the patients who try to ignore that there's anything wrong with them, and they're very achievement and goal oriented. They try to just plug on as if nothing is going on with them. So our thought is that maybe these sort of patients with these different psychosocial behavioral profiles may benefit from very different treatment approaches. I have to thank my Torontonian colleague, Mark Bailey, for these analogies. The idea that with some patients we might want to crack the whip, and others we would pull in the reins, right? So people with this more endurance profile. And then if we match patients to treatment, we might get more impressive therapeutic benefits. So this is sort of the basic idea. You take people into a study, you do this profiling on them to figure out how they're coping, more of the avoidance type or endurance type, and then you match them to a treatment that fits. So people with the avoidance profile would get graded exposure therapy essentially, and people with the endurance subtype may benefit from pacing strategies and mindfulness and assertiveness training and that sort of thing. So that's something we're doing now. Just want to thank some other key collaborators in the work that I've shared with you today. And that's it.
Are there any questions? Charles?
So how do you balance avoidance, maladaptive avoidance, as you pointed out, with the commonly given advice to only do activities, either cognitive or physical activities, up to what we call threshold? And most clinicians now use the term threshold, and that it isn't really, there's no evidence that going beyond the threshold hastens recovery. In fact, most of us feel that it delays recovery if you continually do activities that bring on symptoms. So are you going to call all of that avoidance and maladaptive? And what is the...
Yes, I am. No. No, I think I share your view entirely. So not straining your brain too much in the days after concussion is probably a good thing. It's not clear at what point avoidance becomes maladaptive. It is clear that at some point it does. So that we see patients, weeks, months, years after who can't go outside and walk down the street because it's too bright. At that point, I think most people would agree that you're out of the window of concern where increasing metabolic demands or sensory exposure, whatever, is going to damage the brain. At this point, avoidance is probably maladaptive. We certainly don't want to flip patients over from the avoidance to the endurance style, where they're not doing anything and then they push themselves over their limits, over their threshold, feel terrible, recuperate from that, and then start all over again. So we are trying to find the right balance in between, and that's why some individual support in a therapeutic context is important. I feel like it's difficult to give people advice just in a 15-minute consult about how to return to activity. These patients who are highly avoidant or highly on the other sort of side of the spectrum often need a bit more support in figuring out how to find that balance.
Thank you for a great talk. I'm a neurologist, and this past week in my journal watch, an article came through that was published in JAMA showing that people with mild traumatic brain injury without loss of consciousness, mostly U.S. veterans, had a doubling risk of dementia later on in life. What's your take on that, and as a neuropsychologist?
Yeah, I think as we heard about this morning, there's growing evidence for brain injury of almost any severity as being a risk factor for later neurodegeneration. It's not really my area of research, so I don't have much to add on it in particular, but would invite others in the room to comment. Or not.
Maybe later.
Thank you. Yeah.
Okay.
Do you think resiliency can be taught, or is it something that's, you're sort of, you come from a resilient family, or
Right.
there's programs now in schools to teach resiliency?
Yeah, and also in military service, they're also sort of innovating as part of training military service members, especially before they sort of head into conflict, how to be more resilient. I think we don't know exactly how effective that training is, but people are certainly trying it. Traditionally, it's been thought of a personality trait, something you're born with, and undoubtedly your upbringing has an impact on that. But there's at least some evidence, and we'll see how that shakes out in the coming years, that intervention can enhance resiliency.
Question about us primary care physicians and people who see them rather quickly and initially. And we're taught to assess people quite thoroughly, so we end up giving people these SCAT3 tests, and we do the whole list of symptoms, and we get them to fill it out, we go review them, or else we'll do river meets. Do you think we're paying too much attention to that whole assessment of their symptoms rather than good advice and treatment at that time? And I don't know how to balance that, but I mean, we're taught one thing and then we seem to be having consequences.
Yeah, it's a great question. I think there is a balance there. I think doing a thorough assessment in your initial visit is still probably best practice. There may be some patients who are particularly susceptible to suggestion, are vulnerable to influence in that interaction, and come away being more concerned and vigilant about their symptoms. So, and there are sometimes, if they're new patients to you, they might be difficult to pick out. So I would encourage you to stick to what most people would agree is best practice. For those patients who you're worried about, though, just really encourage the focus to be on a graded return to valued activities, and that it's not necessary to sort of scan your body and on an hourly basis and make note of every time you forget or misplace something. That's probably counterproductive. Yeah.
No, I do want to do thorough assessments. I'm just wondering if perhaps patients should be generating their symptoms rather than us exploring every one of them, and maybe trying to work with that rather than, having our staff give them all these forms to fill in, and then we review them with them, of course, and we want to know what they're feeling, but It's just one of those things.
Yeah, there's been a few studies comparing sort of an open-ended interview question, what symptoms are you experiencing, with giving the same patients lengthy questionnaires. Patients do endorse more symptoms when you give them questionnaires. Whether that puts them at risk of persistent symptoms, I mean, we haven't done that randomized control trial, I don't know, but there's probably a little bit of reason for concern.
No, since we have a few more minutes, could I think someone's starting to clap for you already. No, I was going to ask if I know that some of the people in the audience are very concerned with and have advocated for knowledge translation of what we've learned so far about concussion. I'm wondering if you could tell the audience a little bit about what you've been doing around educating frontline clinicians. Would you mind? Am I putting you on the spot like that?
No, that's just fine. We'll have a word later. For most of what I've talked about today, we're not yet at a point where we're ready to we're not sure what clinicians need to know yet at this point. We're still figuring that out. So yeah, the other part of my research program is taking what we are pretty sure we know about concussion and making sure that that information gets into the hands of the people who need it. And our focus is on primary care, where we feel like patients have the most interaction and opportunity for early intervention in those sort of days and weeks following injury. So we are there any O&F people in the room? Yeah. We are making heavy use of your guidelines. I think it's it's a great piece of work that synthesizes knowledge in these various areas, and from there, taking out the more sort of priority guidelines for the primary care setting. So in this work, family doctors become our research subjects, and we try to influence their behavior in one way or another. So we have, for example, a study where we do outreach visits, going out and teaching and providing support about return to activity guidelines in that way. And then we have other more sort of low-cost, scalable types of interventions where we're having patients fill out some screening questionnaires of what the ONF guidelines sort of flag as the primary symptoms, the ones that ought to be treated first, like headache and mood and sleep difficulties. And we feed the results of those screening test results back to the family physicians with an associated treatment algorithm. So for example, your patient screened positive for depression, action required. It actually says that on the letter because our family physician consultant said if it doesn't say that, they won't read it. And then gives them some helpful guidance about how to initiate treatment for that condition. So by the time patients come to our outpatient specialty concussion clinic, I'm sure it's similar elsewhere. They've already seen their family doctor a number of times, and hopefully rather than having missed an opportunity for earlier intervention, their symptoms would have been recognized and a treatment would be initiated already.
I think we'll have to end it there. Thank you so much, Noah. Very informative.